Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary D. Bartolo, Associate Professor of Nursing at Salisbury University and host of the program. The topic for today's program is oral cancer, and my guest today is Dr. Gregory Allen. Welcome back to the program.
Thank you, Mary.
You are a dentist and you practice here locally in Salisbury, and we are going to talk about oral cancer. First of all, tell us, what exactly it is and how common is it?
Oral cancer is something that the cells in your mouth decide to grow uncontrollably, basically, Mary. It can spread to anywhere in your body, and it's a lack of the cells being able to stop growing. Okay, oral cancer is fairly prevalent. In fact, the statistics tell us that about 1% of the people born today in the United States will come down with some type of oral cancer. Oral cancer is grouped into a larger group of cancers called head and neck cancers, and oral cancer accounts for over 80% of these cancers.
And when we say oral cancer, we're talking about inside the mouth, the lips,
yes,
the tongue?
the lips, the tongue, the cheeks, the gum tissue around the teeth, as well as the back of the throat called the pharynx. Okay.
Oh, okay.
Yeah.
Tell us about what the risk factors are. You're saying it's growing. Is it because it's associated with certain risk factors?
There are several risk factors that play a role in this. So we know for a fact that people who drink have about a twofold increase of developing oral cancer.
So alcohol intake?
Alcohol, any type of alcohol at all increases your risk of cancer. The more you drink, the more at risk you are. Smoking increases your about threefold. So if you look at smoking and drinking together, you would think twofold and threefold. You'd be 5 times more likely to develop oral cancer. In reality, what the studies tell us is that anywhere between 15 and 37 times your chances go up of developing oral cancer, up to 37-fold when you smoke and drink.
And when we talk about, you mentioned smoking, but isn't it all the different types of tobacco used?
Absolutely.
Pipe, cigar, snuff?
Yes, there are various types of cancer. You're more likely to see lip cancers and cancers of the cheek with somebody who uses a smokeless type of tobacco. Pipe smoking is very bad about lip cancers. Okay, so but they're all cancer. And most of the oral cancers that we see are called a squamous cell carcinoma. About 90% of all the oral cancers are squamous cell, which means that you develop a cancer on the thin coating inside of the mouth. The other 10% are made up of mucosal type cancers, muscle type cancers, cancers of the nerve, as well as the salivary glands.
Now you mentioned pipe and cigar would be the same with the lip.
Pipe and cigar would be the same with the lip, but you got to remember that the smoke is still going back. So we also see an increase of cancers on the soft palate, the part of the roof of the mouth that's movable all the way in the back with pipe smokers, because usually that's where the smoke is delivered.
It's passing through.
It's passing through. It's hitting the top of the mouth. Something too that if you look at these oral cancer statistics, we're seeing an alarming rate of cancer in younger people now. The average age of cancer diagnosis in the United States is about 60, 62 years of age. We've been seeing a lot of patients now in the 20s and 30s, and there seems to be a correlation between HPV or human papillomavirus and the development of oral cancer. One study that was really fascinating that was done not too long ago actually showed that in these younger patients that 90% of all of the cancers they biopsied contains HPV-16, which is a subtype of the human papillomavirus.
So HPV that's in the mouth, because I think we normally think of HPV in the genital area.
In cervical cancer. It's one of the main culprits in cervical cancer, and now we know there's definitely a correlation in HPV as well.
And what about sun exposure to the lips? Can that be a risk factor?
Always. We always look for a good oral cancer exam. We'll always take a look at the lip, and usually sun exposure, if you find lip cancer that's a result of sun exposure, it usually occurs on the lower lip. You'll never see it on the upper lip, and that's because most of the time people, I guess when you're walking, the sun's coming down, it's unusual to find any type of pathology associated with sun exposure on the vermilion border of the lip. Okay.
That's a fancy word, vermilion border.
It just means it's the actual outer portion of the lip where the lip stops and the skin begins.
Oh, okay. All right.
And that's usually where we'll find them at.
On the border, you're saying?
On the border usually, yeah.
Okay, so smoking, alcohol intake, sun exposure, but to a lesser degree probably,
yes,
but HPV is definitely one of the things that's leading to the rise in cases in younger adults?
Yes, in fact, that's the number one, because smoking over the years is starting to go down. We're seeing less people now are smoking than they were back in the 50s and 60s, I guess. We're also seeing a change too. Years ago, Yeah, we would see ratios. Usually, if you look at oral cancers, it's 2 to 1. Men are more commonly develop oral cancer than women. But if you look back in the 60s and 70s, it was actually more like 6 to 1, and that's because the woman's role has changed over the years. Now, I guess they're smoking. They have the same habits now, or social ills that men
Smoking
do.
more cigars, say?
Smoking more cigars. Smoking more cigars.
You do see that occasionally.
Yes, I do.
Oh.
Yeah.
Now, what would be the signs and symptoms, and then I guess talk about the staging, because if you catch it early, just like with most cancers or all cancers, the earlier you catch it, the better off you can be from
Oral
a cure
cancer
standpoint.
it's one of the most, it's one that you hit on the most important factor of oral cancer. It's a lot of because there's so many vital structures around the oral cavity, the neck, the brain, the head, and in most cancers that we find, the reason there is a 50% mortality rate now at 5 years with most oral cancers is not because we can't treat it or we can't, it's any different than the other cancer. It's because it's diagnosed late. If we can identify oral cancer early, be it stage 1 or stage 2, meaning that the cancer is very small, it hasn't spread out of the mouth yet, it hasn't gotten into the lymph nodes, which is usually where this head and neck cancer or oral cancer will spread to the chains in the neck. That's why
a lot of lymph nodes there.
lymph nodes in the neck, exactly. So if we can catch it early, the survival rate for stage 1 cancer, which is defined as something less than about 4 centimeters that hasn't spread yet. When I say 4 centimeters, about a centimeter is about the width of a dime. So if we can catch it when it's fairly early, we have a 75% survival rate or cure rate at 5 years.
Well, that's good news, and we'll talk about how to best prevent that. I guess seeing your dentist regularly is really important. Now, what would it look like? Like if someone's looking at their mouth or you're looking at their mouth, what would look suspicious?
Well, what we usually do is it's very important. Oral cancer, one thing, you can't always see it 100% of the time. We do our best to find everything. Every doctor does. But oral cancer is usually appears to be white or red. Anything in your mouth that appears pebbly, that has a different texture, that has changed, a lump, a knot, an ulceration, anything that doesn't heal for 3 weeks needs to be looked at by someone, okay, either by your dentist, by a physician, by somebody who's used to looking at mucosal tissue.
Well, a lot of people get mouth ulcers and fever blisters. Is there any relationship there?
That's a great question again. As of right now, no. We don't think there's any strong correlation between the two. The rule of thumb is if you have usually mouth ulcers or any type of sore in your mouth should heal up within about 2 weeks, okay? Anything lasting 3 weeks should be looked at. Most herpetic ulcers, which are fever blisters in your mouth, usually they'll clear within about 3 to 5 days. They're usually gone. Same with what's called Apis ulcers, which are a different type of ulcer that can occur. They're very painful. They're a depressed center, usually very small. They can be large, but usually very small. They'll usually clear up within about 3 to 5 days as well. But if anything lingers beyond about 3 weeks, then you need to have somebody take a look for you.
I know I see it says there's usually a white or a reddish patch of some sort. And are they painful at all?
They cannot be. Precancerous lesions are usually white or red. We call the white ones leukoplakia. And if you look at leukoplakia, the transmission rate, the ability for, or the likelihood of that white patch becoming malignant, becoming an actual cancer, is about 1 to 2%. You know, it's fairly low. If you look at things like the red patches, okay, a red raised patch, it's called erythroplakia. The incidence of it going on to becoming malignant is about 25%. Big difference. And then if you get one that's actually mixed, the two, the white and the red together, they're really scary because usually what that means is that the cancer is developing different avenues of blood flow and things, and that's something that definitely needs to be seen very soon.
But if it's just white, do you treat that then? If that means it's not likely to develop into cancer?
As a general rule, it depends upon the degree of this called dysplasia. As cells change, they go through various stages. Normal healthy cells that are not dysplastic, we don't. We usually keep a close eye on it. But if we see dysplasia, as a general rule, we will biopsy it. We'll send it to a pathologist. The pathologist will look at it, and that's really where the diagnosis comes from. If it comes back as mild to moderate dysplasia, meaning that there's some abnormalities. If it's a small area that we can remove or laser off, then we'll do it. If it's something that's large, that requires or is more advanced, and it looks like it has a tendency to become malignant, then that changes the whole ballgame. Then you need to go see either a head and neck surgeon, an oncologist, who will get you funneled into the right people to help you.
Now, when you see those patches, white patches inside the gum, do you normally suspect that there's use of snuff going on, or is that just a general place they can occur?
If the patient tells me that they're using snuff and I see a white patch, then usually we usually have the patient abstain or stop using the tobacco for several weeks. Okay, at the very least have them move it to a different area of their mouth, but we tell them we want them to stop using it. And most of the time that we call them snuff patches, little white areas of leukoplakia will actually clear up. If they don't clear up, then that's an indication to go back and biopsy something. In my office, if something looks like it is fairly benign, what I'll routinely do is I'll bring the patient back in 10 days, I'll re-examine it. If it's still there, then I'll take a little piece of it and send it to the hospital to make sure that it's not malignant, that it's not anything to worry about, and then we follow it very closely.
Okay, so once there's a lesion, diagnosing it, you're saying you can biopsy it, that's the best way?
There's several ways to do this, and there's a lot of new gadgets and gizmos now on the market that we use. Modern technology is wonderful, and there's actually, here are some examples of some things that I routinely use. This is called a Velscope, and what this does, this has the ability, it emits a certain wavelength of light that you can pick up normal tissue from abnormal tissue, and this is a wonderful screening tool. It's very accurate, but it's not the total answer. It does not take the place of a good old-fashioned exam. But we also have something here called a CDX biopsy kit, and if you see anything suspicious, we can use this is called a biopsy brush. And what this is, it's a little, very stiff bristled, almost like a stiff bristled toothbrush that has the ability to remove superficial cells. We'll roll it on the tissue, and then take some of that tissue and deposit it on a slide and send it to a lab where a computer reads it. The computer then sends us a result in about 2 weeks, and it tells us if the cells are abnormal or if they're not. Usually, this is a wonderful screening tool, but it's not the answer. Usually, a good biopsy requires an incisional or an excisional biopsy to take a piece of the tissue to send to the pathologist. But all these things are great, but none of these things replace a good old-fashioned, good, thorough investigation, a oral exam. And for that, we use a high-intensity LED light, which gives us the ability to see the tissue very clearly. We can also use magnification, which allow us to see the tissue very clearly, much better than we can with our eyes, to a better visual inspection. We'll also use either a tongue depressor or a dental mirror, which will allow us to retract the tongue and to see some areas that we can't see with our eyes. Some air, basically to dry the tissue, because mucosal tissue looks different when it's dry. This is probably one of the most important things that allow us to see clearly that tissue without the covering of the saliva on it, and that'll make tissues look totally different. And the most important thing, which is a good gauze so we can grab a hold of the tongue and actually pull it from the mouth to do a good visual inspection of the back of the tongue and under the tongue, which are the areas that most of the serious type of cancers occur, on the side of the tongue as well as the very base of the tongue, which are the ones we definitely want to catch.
Yeah, that's what I was wondering. How often do you see cancers under the tongue?
It's not that uncommon. We also do a good palpation, Mary. We actually as we pick the tongue up, we'll actually feel the floor of the mouth and check the lymph nodes as well. But we do see cancers under the tongue fairly commonly. I would think, I would probably say a third of the cancers that we see are either on the lateral border of the tongue or under the tongue. And those are the ones that are the most concerning, because they're the ones that have the best blood flow, are more likely to get out of the oral cavity and spread to other areas.
Well, let's talk about treatment. Like, if you find a lesion and it is positive, so what are the treatment options for this?
There's so many today. Usually oral cancers, first thing we do is we make referral to usually a cancer center, where the patient is evaluated independently at a tumor board. Okay, what happens is they'll sit down with several different types of doctors and they'll come up with the best treatment options or plans for an individual patient. Oral cancers almost always include a surgical removal of the cancer when they can. Now, there's so many vital structures in this area that they can't always use surgery, but that usually is the treatment of first choice, followed by sometimes radiation and sometimes chemotherapy. But this is something, again, that your dentist can play an absolutely crucial role, because as you go through this, a lot of patients want to undergo radiation therapy. There's major changes that occur in their mouth with salivary flow, with ulcerations during treatment. And this is something that your dentist can really be a pivotal, some help as you go through this.
So you're saying there's lots of ways to treat it, but the key is catching it early so that you don't have to do anything too drastic.
Yes, absolutely. The earlier we catch it, stage 1 or stage 2 cancers, 75% curable if we find them early.
Well, I hate to bring up an example, but I think it was a good lesson to everyone. Didn't Roger Ebert have some sort of mouth cancer, and he needed pretty extensive surgery, altered his face and tongue
absolutely
significantly.
And morbidity, it's a hard. That's another thing. It changes people's. A lot of oral cancers or facial cancers can be very disfiguring too,
right?
And that's very difficult because people are very conscious about their appearance.
It's your face, and not only is he's disfigured, but he has to speak using a computer and such because it had spread quite a bit. I just want to emphasize the importance of the early detection and seeing your dentist regularly. And regularly means at least once a year, if not twice. At
least once a year. And there's a misconception out there too that a lot of folks don't have any teeth left, and we see that quite frequently. Another sign or symptom that we look for is an ill-fitting denture or an ill-fitting partial. Sometimes when people don't have any teeth, they think they don't need to go see a dentist, but somebody should be looking in their mouth at least once a year to catch these cancers early.
So whether they have teeth or not, they should still be getting exams.
Absolutely. I tell all my denture patients once a year. We want them in there once a year.
Well, let's wrap up just emphasizing prevention, because that's what we're about. Try to prevent these things from happening. And of course, you mentioned some of the risk factors. Let's go back to those and things people should avoid doing.
Smoking, threefold increase right out of the bat. Smoking all by itself will increase your chance to develop oral cancer by threefold.
And you're talking cigarettes or general tobacco?
I'm talking cigarettes, general tobacco. You have a threefold. If you use tobacco, your chances of developing oral cancer are significantly higher. If you drink, your chances of developing oral cancer are higher. If you smoke and drink, 37 times likely to develop oral cancer. That's a very scary prospect. And knowing that 50% of the people that are diagnosed with oral cancer won't be alive in 5 years, is it really worth it?
Exactly. And of course, being careful in the sun. I guess, they do sell lip products that have SPF in them, if that's helpful. I know a lot of people get in the habit of using those on a regular basis. And what about the HPV risk factor? It's
younger populations. That's something that's very new. We're starting to see more and more of this, like I said. And the type of cancers that we're seeing too are a bit, they're not typical presentations, especially not younger folks. So there's a wonderful vaccine out there, Gardasil, which I'm not sure the efficacy yet, but I can see it coming down the pike. I would think they would have prevention as well for men and women.
Of course, I'm assuming the way that happens is with oral sex.
That would be it. That's the current thought now. I'm not sure if we're 100% there yet, but that's what the current studies seem to indicate.
And of course, seeing the dentist regularly, we've emphasized that, and just good oral hygiene yourself, and looking at your mouth and your lips.
Always good. So you can if you notice anything that sticks around in your mouth longer than 3 weeks, then you need to get in and see somebody. And it's a lot of people don't want to look in the mirror, pull your cheeks aside, grab a hold of your tongue. It's the funniest feeling in the world. My patients, it's almost comical because when they sit in my chair, they get this habit. I can go through my exam and they know. I reach for my galls and their tongue comes out. This is often a joke in the office, but it's a good joke.
But generally speaking, other than the HPV, it's older. The risk occurs more so in the 60s, you're saying? 62
years old is that's the average onset of oral cancer, 62 years old.
But I guess it's a good idea to keep a good eye on things anyway.
Always. I've seen many patients over the years in their 30s and 40s that it might not be of an oral source, but we find cancer. And it's always a good idea to everybody to see your physician regularly, see your dentist at least once a year, if not twice.
And I imagine, especially for using snuff and cigars and even smoking and all those things, yeah. So
that's something too that you can always approach to your dentist about helping you with tobacco cessation. That's a big avenue now, and we're trying our best. We've had wonderful luck in the offices with Shantex and with Wellbutrin and some of the other anti-smoking drugs now that are available for people out there.
Yeah, there are a lot of resources. We've done shows on that in the past too, because smoking is such a risk factor for so many things.
Yes.
And the local health department, the American Lung Association, people can get help, and you need the support piece with it too. So It's good to know the dentist is there to help.
Great. Well, we're glad to be there.
Well, thank you, Greg, for being on the program, and just a great informative talk about a very important topic.
Well, Mary, thank you for having me again.
And we'll post some websites at the end of the program where people can get some more information.
Good.
And thank you for joining us for this edition of Focus on Health here on PAC 14.
Focus on Health is sponsored by Peninsula Regional Medical Center, a proud supporter of PAC 14 programming.